I'd like to welcome you all back to this afternoon's session for the first day of our building capacity training. In 2022, the Association celebrates our 45 years of service to stroke survivors in New South Wales. During that past 45 years, there have been significant changes and progressions of stroke care. These changes have often been a long time in coming and have come about when clinicians were able to unite in the interest of better stroke care through the organisation that is now known as the New South Wales Agency for Clinical Innovations. It's had many iterations over the years, but basically the people that were involved in that organisation and the organisations pre that, very, very smallly pre that, really pushed for stroke treatment to become much more formalised and provide much better services to survivors of stroke. Along the way, there have been many stroke champions who have been part of these changes, and we are extremely fortunate to have just a few of them here to present as panellists this afternoon. This will be a much less formal session and will be a guided discussion covering the changes that have occurred. Our panel session will be facilitated by Associate Professor John Worthington, Director of Stroke Services in Sydney Local Health District. However, I would like to introduce our other panellists to you. I'm not going to go through all their information because you all have a copy of our speaker booklet. However, starting from way over on my right, I have Miss Brenda Booth Oam, who is an advocate, a stroke advocate, and has been very much part of the development of stroke services throughout the past 20-odd years, odd being the word, okay. Next to Brenda, I have Associate Professor Martin Krauss, again, somebody who has not only got a local focus but also an international focus on the changes in stroke, because Martin did his training over in Germany and has come over to Australia to work here. Next to Martin, I'm really quite privileged to introduce you to Honorary Professor Cate Storey. She's honorary, she tells me, because she no longer gets paid. However, so Cate is one of those real stroke champions that was really part of the push for stroke services to become much more formalised in the late 90s and early 2000s, going through to the end of her career. And of course, the facilitator today is Associate Professor John Worthington. And most of you will know John because I've forgotten you, Martin, haven't I? Sorry. Sorry, Martin. And coming in online, of course. Is he pulling faces at me because I can't see him? That would be right. Coming in online, we have the wonderful Associate Professor Martin Jude from the Wagga and Riverina. Oh, is it Southern Local Health District now? They keep changing the names of these things on me. So it's Southern Local Health District. And Martin has been a real champion for stroke in rural areas. So we're really brought together, hopefully, a really good team today to have this discussion. And I'll now introduce you to Associate Professor John Worthington, who has been a real stroke champion and runs is the Director of Stroke Services for the Sydney Local Health District and runs the stroke program along with Kylie. I'm putting you up there, Kylie, at RPA Hospital. So over to John. And thank you all for coming.
Thank you, Michelle. It has relied on the advice and the advocacy of this organisation. It's been a major focal point when we're giving advice or basically begging the health system for resources, but it has also provided us with important feedback to make our services better. I certainly do know who really runs our stroke service, Kylie. None of us, I'd like to say, were around doing stroke in 1977, although clearly we're all over 35 now. But we are blessed because Cate Storey has a long interest in history She's a medical historian, card-carrying medical historian. And I'd just like to ask her, what was stroke looking like in 1977, when the association was very young, and what got your passions going?
Thank you, John, and thanks to Michelle for asking me along to this. It's been a while since I've actually been in clinical practice, but as you've heard, I've actually become a historian. I can't carry an academic historian, but no matter. Anyway, in 1977, I was actually a medical registrar. So there were people around in 1977, John. And looking around, I probably am the oldest in the room, but in 1977, I was the medical registrar. And to be perfectly honest, I would never in my wildest dreams would have thought of becoming a stroke physician in 1977. In fact, as a medical registrar, the worst sin that you could ever commit was to accept a patient through the emergency department with a stroke. Because for the consultants who only had 1 or 2 beds, it meant that that bed was going to be taken up for 3, 6, 9 weeks at least, while the patient often just languished, which was an appalling situation, but nobody wanted stroke patients in hospital. So small strokes were managed at home, or the rehabilitation was just non-existent. But that was the situation. So if a patient actually came in at that time, got past the gatekeepers of the emergency department, they were either subarachnoid hemorrhages and would go quickly to the neurosurgeons. But even in those days, a subarachnoid hemorrhage meant 3 weeks of very strict bed rest. And by bed rest, I mean sandbags on the head, doing absolutely nothing for those 3 weeks. They may have had a carotid angiogram, but it wouldn't have been a nice carotid angiogram that you would have done. It was a direct carotid puncture. And even that had such a high mortality rate. So it was an appalling situation. For the other strokes, there were either thrombosis or hemorrhage. And the only decision that a clinician had to make was that if it was a thrombosis, they would go on to heparin. And if it wasn't a thrombosis, and they had a hemorrhage, they wouldn't go on to heparin. So that's the only clinical decision that had to be made when a patient came in, and there were no means of investigating. So how did we work out then between a hemorrhage and a thrombosis? Not easily. And the reason, and what we did was a lumbar puncture, and if the lumbar puncture showed blood, even if it was resident-induced blood by a lousy lumbar puncture, the patient didn't go on heparin because it was likely to be an intracerebral hemorrhage. And if there was no blood, then it was likely to be a thrombosis, and therefore they got heparin. That was all the decisions that were made, and there was no way of investigating it. Now, as a true historian, I thought, why are you celebrating 45 years? What was it 45 years ago that made people think, why the hell do we need a stroke recovery? Because there wasn't the impetus for stroke and recovery, etc. And I think that the reason was that CT scan became available in 75-6. And I can't tell you the difference that made at that particular time, because we could now actually see a stroke. And once we could see a stroke, even on those CT scans that were absolutely appalling, and I just happened to have the first CT scan that was done at North Shore on a case of cerebral hemorrhage, it was appalling CT scans, but we could see, and we could see for the first time a hemorrhage, a thrombosis, a stroke. And I think the fact that we could now see a stroke actually excited everybody's interest in stroke, and the fact that we could actually look at it, think about it, do something about it, made such a difference. And that's personally why I think that the Recovery Association started 45 years ago.
And was that around the time you took an interest in stroke?
No, I still didn't. No, I didn't. If you want to know why I took an interest in the stroke, many years later, a lovely lady gave some money to North Shore Hospital to start for stroke. And we had lined up a stroke physician who had trained at North Shore, who had gone overseas, who came back to Sydney, but unfortunately he didn't take up the position, and it looked as if we were going to lose the money. And so I said, I don't want to lose. It's a bit of money. I am Scottish. I don't want to lose that money. And so I became interested in stroke just to hold on to that money.
Following the money tack will become common threads, I think.
John, can I ask you to hold the mic close to your phone face, John? It's just not picking up your voice very well.
I'm sorry. Martin, I haven't forgotten you. What got you interested in stroke? Where did it all start for you?
Well, there are two Martin. Krauss and Martin Judy.
Martin Jude will do nicely.
Thanks, John. I'll start by congratulating Michelle and the Stroke Recovery Association. I'm sorry I can't be there today, but that's the nature of being in Wagga, so welcome from Wagga. My favourite story about stroke is that I recall sitting in an office, this is 15 plus years ago, receiving a note from the Ministry of Health which said, we'd like to announce funding for stroke unit care. And I thought, well, that's fantastic. So Wagga needs a stroke unit. So I looked it up, and of course there were about, I think, 11 or 12 units, and they're all in Newcastle, Sydney, Wollongong, and I was naive enough to think that there'd been a typo. And where were the regional units? So I was a little bit simplistic in those days, and I contacted some contacts with the ministry and said, there's been a problem with your brochure. There are no regional stroke. And they said, oh, well, it's only a metropolitan structure, really. It's got nothing to do with regional, because that's not a priority. And boy, oh boy, that really started a whole interesting conversation. So that started an advocacy issue for trying to make the claim that there was a requirement for the same degree of intervention, support, stroke unit funding for regional Australia, and that wasn't easy. And I think on the panel, most of us have met all the health ministers over the years, and it took a long time to actually make what should have been a very simplistic case for stroke management. And as Cate has said, I trained in Sydney and then went to Oxford, and in fact, stroke was considered beneath neurologists. Neurologists didn't deal with stroke. It wasn't an appropriate neurological condition. But that's been completely revolutionised by better quality imaging and structure. And it reinvented my work in Wagga. It really was a fantastic impetus, and it's now become a major part of my work. And a lot of that work was really getting funding for regional stroke care and regional stroke support nurses, and we can see now that really enhancements in stroke management are now considered as statewide enhancements, not just metropolitan enhancements. So it's been an amazing transition of my work. You know, I was already 10 years working in Wagga at that stage, but extraordinarily rewarding.
Thank you. And to put this in context, Martin is the medical lead of what's arguably one of the best stroke units in the state, not just regionally. He's done an extraordinary job in Wagga. And the rollout, what was it, around 2008, of another 8 funded stroke units in the rural sector to get things kick-started after the emphasis on metro. Thank you. Thank you, Martin. Sarah. Fender, sorry, my mistake. I blame somebody else for the Sarah mistake, but
okay.
Brenda.
I answer to anything, so that's okay. Look, stroke survivor, I need my notes. What can I say? Look, my involvement in stroke actually started back in the early 80s. I was a baby registered nurse, and I started at Royal North Shore Hospital. That was my training hospital in Ward 8B, where Cate Storey was a honorary doctor. and so so I sort of working in the neurology ward, as what Kate's saying is, we did get stroke patients, but there really wasn't any treatment. They were just we provided nursing care, but that was about it. And I remember there was this very young lady who came into Ward 8B. She was in her early 20s. She was very fit, active. She was a ballerina, and she had had a really devastating stroke. And all of us young registered nurses kind of went, "Oh my God, that could be me." And fast forward 20 years, it was me. You know, I had a stroke in 2001, and then getting involved in sort of stroke as a consumer, I joined the State Stroke Network, and it's had quite a few name changes, but it's now the Agency for Clinical Innovation. And so, yep, that's where my stroke journey has been from. So, thank you.
And you've been an essential part of all of that process. And you've been at more meetings, I think, than any of us in the room, I suspect.
Thank you, John.
Martin. Martin Jude runs one of the best services in the state. You have the additional distinction running a good service, but one of the largest in the state. What got you interested?
Interesting enough, stroke was not my first love. I trained in Heidelberg in Germany, which is the biggest hospital conglomerate in Europe. So we serviced 4.5 million population. It's the biggest hospital in one of the biggest in the world. And I trained and worked there for 12 years. And my first love was movement disorders. So I got interested in deep brain stimulation for movement disorders and Parkinson's disease and generalized dystonia, but you couldn't avoid dealing with strokes. We had 1,000 strokes a year and we did 200 thrombolysis, and my boss and mentor was Werner Hacke, who was one of the godfathers of thrombolysis. He ran the ICAS trials, and you had to be involved. You couldn't not be, and we ran a 12-bed stroke unit there. And so stroke was part of our daily work. And in 2007, I got an offer to come to Australia for an academic position in Nepean. And I really loved Australia, so we resettled in Australia in 2007, and it was quite a cultural shock for me, you know, coming from a large hospital with 12 consultants and 30 junior doctors in neurology alone. I went to a department with 4 consultants and no junior doctors at all, and a just freshly opened stroke unit. And so I was very concerned about the on-call burden and said, oh, you know, 1 in 4, it's really a lot, you know, being used to high level in Heidelberg, and the department head at the time said, oh, don't worry, I haven't come in for 6 years. And I thought, that's strange, you know, don't they treat stroke patients? And I realized the emergency department was largely running the stroke service. And there was a lot of resistance to thrombolysis. And it was really hard. They didn't believe that thrombolysis makes a difference. And so the first 30 patients in Nepean, I had to thrombolyze without any support, single-handedly, basically, because the ED said, oh, we don't think it helps, and it's a big risk, you know, we don't want to be part of this. And it took 30 patients to really convince them that it's a beneficial treatment. And while in Heidelberg we operated an MRI 24/7 and access to an MRI at all times, and so our stroke patients never saw a CT scanner, in Nepean it was hard to get a CT at night, you know, to differentiate between a bleed and an ischemic stroke, which would be treated totally different. So it was quite a journey for me, and I, you know, then moved to Royal North Shore 3 years later, which was very different to Nepean. And I think there's great inequity still within Australia in regard to stroke services and availability.
Thank you, Martin. I too was an accidental traveller. I'd given a few talks at Prince Alfred on stroke syndromes just because I was trying to prove that I was interested in neurology. I'd done neurology research in something completely different, as Martin had done. And then the stroke physician at Prince Alfred, the lovely Rick Mulhern, who just did one outpatient clinic on stroke each week. It was a funded thing, again, money. I had an FRACP, and no one else wanted to be the stroke physician. I hadn't even finished neurology training, and I found myself the stroke physician at Prince Alfred to keep the funding, and doing the stroke clinic, which largely went around saying, oh, well, take the aspirin or take the Bosantin and best of luck, because this was the era where you came under whatever team, you perhaps went to a veranda bed on some aspirin and you took your chances. Again, the CT scanner arrived and things changed somewhat, but not much. So in 1997, which is a highlight of the history of this association, one of the guys that was a resident when I gave my stroke syndrome talks had found out that we'd put a few stroke pathways in at Manly, and that I was obviously a stroke physician. And I was invited to that 1997 workshop where both, for the first time, the New South Wales Ministry of Health had decided stroke care mattered. The federal government a year earlier had provided a bit of stroke care funding, again recognising that stroke care as a particular disease mattered. And from there was a little bit of impetus. Andy Evans, who was at Westmead, published a paper showing just how good stroke units were, although they'd existed in the 50s, even in the 60s, in a few isolated pockets around the world. So we had something to wave at people. And then we had a stroke network, as Martin suggests, of 22 hospitals that tendered for the job. One of our tenders got up, and whether I liked it or not, I've not been able to shake off being a stroke physician ever since. But at that time, I think we were so far behind cardiology, probably 2 decades behind cardiology, if not 3. And the work of so many people, including people not sitting up here, means that I don't think we're behind them anymore. I think we're past them a couple of years ago, and I no longer have an inferiority complex when I bump into my cardiology colleagues. Thank you. So we mentioned the stroke units. So what were the main challenges of setting them up? I might come back to Martin Jude on that, because they left him off. They put him on the mailing list, but left him off the funding. So, what were the main challenges, Martin? Martin Jude.
Well, look, I think the main challenge was really trying to structure a cohesive service that covered where the population is. I think that was also training people, and really the benefit of stroke unit care is not really about the medico who's there. It's about the nursing staff and the physio and the speech pathologist and all the other ancillary staff who need to be educated. And it was an exciting time actually, because there were educational opportunities and really great learning opportunities to teach people that you could actually make a difference. So I think teaching and retaining those staff with expertise and really training them from the ground up, that was one issue. The other, which I think has worked reasonably well, it's been a bit of a success story, I think, and that's the geographical spread, to make sure that wherever you are, that an ambulance will now take you to a stroke unit. They will avoid taking you somewhere which doesn't have a coordinated stroke service. Now, that's easier in metro. It's more challenging in rural, but not impossible. And now, of course, you see all the other services and management of how to access stroke unit care through ambulance service, telestroke services. There are still gaps there, but compared to some years ago, some really fantastic results. And also being able to compare results with your peers and with overseas results. So it's really, as you've said, John, it's brought us up by the bootstraps and really created this fantastic networked service. And stroke clinicians are actually nice people, I'd like to say, in the main. They're friendly, collegiate, there to help, and we've seen this transformation of care, and it really is still a statewide network. But I think the challenge initially was really getting that staffing and the funding, of course, which came on board, and maintaining all that fantastic knowledge base that we've now got throughout the state for coordinated management.
Thank you. Thank you. So, rural, you were there, Catherine. I remember you telling me that the first thing you had to do was to put a sign up saying stroke unit, and then it would all be okay from there, maybe. But what do you think the drivers were?
Is Liz O'Brien here? No, she's gone, has she? All right, what a shame, because the thing that always surprised me, that coronary care got up and running so quickly in the 50s, and the first coronary care unit in the world was actually at Sydney Hospital here in Australia, which is really extraordinary. And the thing was that people recognised that patients were dying of myocardial infarcts because of the complications, and the complications were an arrhythmia. And so some smart chap at Sydney Hospital thought, if we could pick up these arrhythmias quickly, we could save these people with myocardial infarcts. So they thought, rather than running around the hospital trying to find all these patients with arrhythmias, if they put them all into one area and taught the nursing staff how to recognise arrhythmias, then they would have a much better chance of recognising complications and saving the lives of patients with infarcts. And that's just what they did. And it was a monumental shift, because it was the very first time that nursing staff were empowered to manage patients. So there was no question. If the nursing staff in the coronary care unit recognised an arrhythmia, they then were able to treat that arrhythmia. And this was a huge seismic shift in patient management. So it was 30 years before anybody actually thought of putting all the patients with stroke in the one area, so that the nursing staff and the ancillary staff could recognise complications that were actually going to kill these patients or make their life a lot worse. And I had seen overseas that the stroke units were developing, and I think probably the last straw was that as a neurology consultant, I used to see patients who were admitted under my care, and I might start off in the neurology ward, but people who came in overnight were in the orthopaedic ward. I've even had strokes in maternity. I've had all sorts of, probably not the men, that was probably the only. But we had patients everywhere, and it was so unsatisfactory, because you would go into the orthopaedic ward and find somebody with a fairly large stroke, and the poor staff in the orthopaedic ward were just not equipped to look after that particular patient. So we thought that if we got all the patients together, just like coronary care, we would have them together, we would recognise the complications so much more quickly, and we'd be able to manage those. And if in the future a treatment, a satisfactory treatment came along, we would have that infrastructure organised. So I'd seen this working overseas, and when I came back to North Shore, it was the typical, we'll put it through a committee and you do a business plan, etc., etc., etc. Now, again, I'm not one for committees and structures and various bits and pieces. So Liz O'Brien and I went out and bought a sign that said stroke unit, and we came back and we actually just put it on the wall, and we put, it was a 4-bed unit in 8B, and we put all the patients who came in acutely with stroke into there, and we referred to this as the stroke unit. And very shortly after, everybody referred to it as the stroke unit. And then we really knew we were in the game when the administration were looking around and they saw this and said, have we ever opened this stroke unit? So we said, yes, we said, we'll have an opening. And so they all came to the opening and we cut a ribbon, and it was fantastic. I still don't know if that committee is still deliberating on this. But possibly, Martin, you'll get a piece of paper in the mail that will say that you've got permission to run a stroke unit at North Shore. I mean, it was just silly, and we knew that. And then, of course, we had the treatment, and we had the infrastructure there to manage it.
Thank you. Yes, it sounds like an episode of Utopia, if you're familiar with the TV show. Brenda, I mean, these are all big changes, not the only changes. We'll talk of more. But you know, what does the rollout of these heightened services mean? They, I hope, get better each year.
Yep. Look, firstly, can I go back to what Cate was talking about? I was really fortunate because my neurologist was actually part of the State Stroke Network back in the early 2000s. And so he had created a high dependency observation ward in the neurology ward, and I was very unstable with my stroke. I actually had the stroke, and then I started having quite major TIAs. And at any time it could have been not a TIA but another stroke. And so having that high dependency observation area, I think actually was the game changer for me, because the staff were skilled and experienced and very keen. And I think if I hadn't have been in that ward where pseudo stroke unit was, my outcome would have been very different. So, but yep, to stroke units, look, they've been game changers. Even in the 18, 20 years I've been watching the progression of stroke units and then further stroke treatments, it's stroke units that are the basis of sort of saving lives and preventing further disability. But the problem is actually not always getting access to a stroke unit. So from a stroke survivor's perspective, it's like, the emphasis is about being cared for in a stroke unit, but that doesn't always happen.
Yes. I think that covers it quite nicely. I mean, if you land on a stroke unit in New South Wales, you match what the Lancet paper showed in 2001, you've got a 30% less chance of dying. But most importantly, you've got a 30% better chance of going home, a 30% better chance of having an excellent recovery outcome. And it's still our most powerful treatment, getting to the right place with the right team of people. And we say right patient, right place, and I would say right team. Keeping that all running to the same quality each year is an immense challenge for those involved. But Martin, in 1995, alteplase, our major stroke reperfusion drug, was licensed for cardiology. In that same year, the NIN study reported its benefit. I think it was about another 8 years before it was approved on the Australian TGA, although we'd been using it off licence. Tell us a bit about TPA, its history and the difficulties of introducing it. You mentioned emergency departments.
As I said, it was very different in Germany because obviously we were running these trials that led to the approval of TPA, and we were treating in 95 already people with thrombolysis for stroke within that ECAS trials. But coming here to Australia was a different landscape. It was run largely by emergency departments. There were not enough neurologists interested in stroke, and it made it very difficult to provide that. And the emergency department doctors didn't really buy into that. And that speaks to the point that Martin Jude made. Stroke care really made a leap, forward when we worked as teams together, when we worked with emergency department, with allied health, in stroke units with different teams. And I think that really brought it forward. I think it took quite a few years and was different in different hospitals for emergency to buy into this. It took years for the radiologists to come to the party and offer rapid access to CT scanning and advanced imaging, and also the development of stroke units.
There are people in the room, some of them had strokes in different places and at different times. But who almost got met by the stroke team in the emergency department? Has anyone? Yes. And I mean, that's the best standard for us now, with the help of ambulance giving us a warning, with stroke teams that are often present for a fair bit of the day.
If I can say one little story from that point. My boss, in Germany, the emergency department is very different. So we don't have emergency physicians. The emergency departments are manned by the subspecialties, so cardiology, neurology, whatever. They share an infrastructure, but there are no emergency physicians. And on one of the academy meetings in the US, Werner Hacke said, well, we are privileged in Germany not to have emergency physicians, which caused a lot of controversy because it was so difficult to convince emergency physicians that stroke is an important disease, and that's a disease that we need to treat. And so from that perspective, it was a very different landscape, and I think that made it easier to adopt these changes early on.
I think a lot of us moved into the emergency department to assist them as part of the process of giving them confidence. So, Martin Jude, I mean, we've talked about thrombolysis, talked about the stroke units, and the benefits of thrombolysis are about 30% of patients, although mortality is a bit iffy in the first few days, 30% of those patients are going to have an excellent recovery that they would not otherwise have had. But of course, access is a big deal. We provide a statewide service to take ECRs, but you've got to recognise the patients. What's telestroke done? You know, we're rolling out telestroke in rural communities. What difference has that made?
I think that's been the next big game changer after stroke unit care for regional Australia, John. Victoria, I think we're ahead of the game. There's nothing worse than having the Victorians beat us to the punch in New South Wales. That's a terrible result. But they really had a very well coordinated system, and it took a little bit of time for New South Wales Health to work out the optimal structure. But there's been a fantastic rollout now regionally that, again, a little bit like stroke unit care, wherever you are, an ambulance will take you to a place where you will have access to a stroke clinician on the end of a video link in Wagga. We're fortunate enough to have staffing where we can do it on site, but you'll have that expertise really that you would get if you were attending Prince Alfred or North Shore or the Hunter online, a stroke clinician who's looking at the patient, making decisions, assisting the people on the ground. So it's a virtual model of care that has really been a fantastic additional support for sites that will realistically they'll never have a stroke clinician on site, unfortunately. But you're bringing that virtually, and I think there might also be an extension that we'll have to get that expertise into virtual stroke unit care as well. So that's been a huge, huge infrastructure improvement and a great success story for the state.
Thank you, Martin. And more people getting reperfused, do you think, in rural areas, particularly more remote?
Absolutely. The numbers are very significant. And it's not just about giving those sort of pointy end treatments. It's about patients who may not be suitable for those treatments, but still getting access to stroke expertise as well.
Stroke management is at least as powerful as what I would call the sexy stuff that might be done as well. I think for us, when we look at our data, we run a state, like there are 3 metropolitan sites offering statewide intravascular clot retrieval. And there's a question that was scripted for me to ask, but I may answer. So roughly about 8 to 10% of strokes will be eligible for that. But in addition to getting your stroke unit difference and just difference from getting the drug, the alteplase, to improve your function, the intravascular clot retrieval in a particularly select group of generally very large strokes that have typically not done well, you gain another 30% of excellent outcomes. But gosh, it's a hard thing to deliver, like TPA was when we first started, to do it consistently and at all hours, which is always a challenge. But with telestroke, I think we were running about 25 to 28 referrers, and I think in the 2021 year, where we've got a bit of documentation, I think our hospital has taken stroke patients from something like 41 referrers, which probably tells you about the reach that telestroke has given us. So what's next? What do you think the most important thing has been for stroke over the time? Yes, for you.
Well, I think actually just putting it on the map as a clinical thing, and that had positive outcomes if managed properly. I mean, that was the game changer when we could actually offer something to patients. But and it has been an extraordinary. I mean, my journey has been extraordinary, from one where we feared strokes coming into hospital to one of excitement when we could see the extraordinary results. And I was privileged to work at North Shore, where we had an excellent radiology department. There was no doubt about it. We were really, really fortunate to have it, and I'm sure it's the same with you, Martin, that we had a radiology department that were very supportive and did a lot of the early intra-arterial work. And I think it brought home to me a young woman who was working nearby at North Shore, and she came in with what would have been a huge, huge deficit type stroke. We got her in, she had an intra-arterial clot retrieval. She leapt off the couch and made the bed. And I think that was, when I actually saw that, I thought that this is where stroke had completely changed. Because prior to, as I said, when I first started, it was the Cinderella of neurology specialties, and the nihilism that went with it was just extraordinary. And now, seeing all of this has been, I think, one of the most exciting. I just had my 50-year medical reunion, and I wrote a book, as we do, us historians, on the 50 years of change. So I was looking through this 50 years of change in the various specialties. But I must say I really enjoyed writing the section on stroke, because to me it was a very exciting change, because it represented not only a change in technology, but a change in a mindset, that it wasn't just a medical condition, it was a social condition, and it wasn't just a doctor who got involved, it was a team who got involved. And it's actually, I must say, I think it's my best chapter in my book about stroke, and I wrote about a lot of other things, and I wrote about a lot of technologies. But I think that stroke was by far the most exciting, and I don't think we've stopped yet. I think it's got still a long way to go.
Have you got copies of the book outside? What goes around comes around. I'm going to have to word this carefully from a privacy point of view, but we'd all met health ministers repeatedly with differing degrees of success. I had one at Manly when we got a new CT scanner who dragged me across into a private place and said, "How did you get this?" Because he clearly didn't want us to have one. But Craig Knowles arrived trailing another well-known political figure into our hospitals some time ago, followed closely by a number of other people that would be known to you, because apparently they were having a nice lunch somewhere reminiscing about the old Labor Party. And it looked like a Labor Party branch meeting by the end. But Craig had actually helped call forth some of the metropolitan efforts around stroke and a lot of other conditions. I do recall we were in alphabetical order the 12th listed network that was going to be funded. I'd like to think that was just alphabetical. But I think it was a great thing for him to see that, to see the fact that it had gone from well behind with no equivalent to a coronary care unit to people meeting him at the door and rushing people off, still on the trolley, not taken off an ambulance trolley, scanned and quickly treated, in which case that happened again for this. But I would like to ask, what's the role of research? What's going forward, Martin Krauss?
Yeah, I think research is really important to inform further developments, and I think Australia has been on the forefront on many new developments, like embolectomy, which was done very early here and very successfully. But also, I think what's always neglected a little bit is primary prevention, so that we learn what risk factors lead to stroke and how we can mitigate them. And I think we in Australia are really good at that. So we have one of the lowest smoker rates in the world. We are generally quite active people. We do a lot of sport. We are very healthy in that regard. And I think that research is really crucial to understand what are factors, that lead to stroke, and what we can do to improve outcome in stroke.
Thank you, Martin. Now, given where we are, and given the fact I kicked off saying how important the association has been, both politically in advising us as to what was important, I don't know if we're actually finishing up, but what is the stroke survivors' involvement in advocating for services?
Okay. Well, look. Okay. Big question, that one. I think being involved in research, but also being involved in the development of the guidelines. So, the national guidelines are the national stroke guidelines. Whoops, just lost my papers. Are the ones that inform best practice. The stroke guidelines cover, every aspect now from, coming to hospital through the acute care, rehab, and onwards. So I think the guidelines have been a huge thing. And now that they're living guidelines, there's many stroke survivors who've had a lot of input into the living guidelines. So that's been a real big thing. John, I've actually forgotten the question.
So what do you think the role of the stroke survivor is and has been and will be in advancing all of this?
Look, having a voice. It's the people with lived experience, so that can be the stroke survivor right through to family members and carers, having that voice about what has made a difference for them. But if they haven't had the good journey that some of us have had, it's like, what can be done to make it different? And it's only by stroke survivors and their families getting involved, having a say, and working collaboratively. It's not about giving clinicians a hard time. It's about working collaboratively so we can actually do and make productive change.
Terrific, and thank you, because just as we used to wave the Lancet paper about the benefits of stroke units, we always knew you had our back when we were trying to get things, for which we were most grateful. I'd also like, we've mentioned nursing before. I mean, I hope nursing and stroke has been a great opportunity for the senior nurses amongst us who, quite frankly, have driven things. I mean, I think the first stroke pathways at Manly, for example, were written by the nurse on a general medical ward who was outraged at the care and tried to fix it. And I rely heavily on Kylie. But again, on the sort of feedback you're talking about. So, Kylie, we did a sim, didn't we, for an ECR, and we did it all very quickly. The clock was running, everything was great, and then we asked the stroke survivor, who was acting as the patient on this occasion, what we could do better, and he did suggest we might talk to him. And then we weren't feeling quite so smug. So we need to listen. It's very important. I like to think that we do, and if we don't, you should shout at us. But certainly I'd once again like to thank this organisation. It's given all of us a chance to make our case at one time or another. There's no one here that hasn't talked fairly often here. It's given us a chance to see how we should do things better. And I would like to thank the team that I know best, which has been the team for a long time, Michelle and her people, both organising today, but also thank them for all of the supports and opportunities over the long period that, because we're over 35, we've been involved in this process. So thank you all rather than thanking us. Thank you.
Thanks, that was great. I really enjoyed that. I hope everybody in the room and those online enjoyed that step through time. And it's wonderful, isn't it, to hear the challenges that people have faced and how sometimes they just went ahead and did things without getting approval. It's always better to give an apology than ask for permission. Isn't that the rule, Cate? I'm sure she had that as a rule. So in closing, I'd like to thank John for facilitating a very interesting and thought-provoking session. My thanks also to the panellists, Associate Professor Cate Storey, Associate Professor Martin Krauss, Stroke Advocate Extraordinaire, Ms Brenda Booth, and the wonderful, fabulous Martin Jude from Wagga. Okay, and I hope it's a lovely day down there in Wagga, and I really thank you for coming on for us today.